Good evening all. Thank you for once again joining with us for the today's session. I welcome Dr. Balaji Chinnasamy sir, Professor of Pediatrics from SRM Medical College for mentoring us in the case presentation series by Medusane. And today we have Dr. Vigneshwar, final year MBBS student from Tagore Medical College and Hospital to present a newborn case. And I thank Dr. Balaji sir for joining us today, for guiding us and for being an examiner for this newborn case presentation. Thank you so much, sir. And now shall we begin it, sir?
Thank you, Paragu. Thank you. And good evening, all of you, my dear students. Happy Diwali. Hope you had a good, enjoyed your festivals. Okay. So now we will start our series from now on. We have like another 3 to 4 months. So every 2 weeks once we will try to do one case related to pediatrics. And we'll have a discussion and I will try to cover up the basic questions which are being asked rather than asking all the complex atypical questions. I will cover up the basic questions which are very important to pass your exams. You must know these questions. Something most of it might be known to you, so it can be a revision. You can keep it as a revision, quick revision for you. And okay, we will start with that. And I have some quick revision modules also. So it will be only for half an hour to 40 minutes each case scenario. Like that, I have 10 to 12 case scenarios. You can register it to view those at www.tinyurl.com/PETS-revision. It's www.tinyurl.com/PETS-revision. So you can register here. I will share all those recorded videos to you. It will be covering all the topics within 30 to 40 minutes so that the time of exams, it will be useful for you. Now we will try to do a question and answer discussion type of what all questions we ask in exams, we will teach you out. Okay. And newborn is one which mostly will be kept for all of you. So it's like very important because in our college, it's kept as a short case. So one long case and one short case. So mostly in private colleges where case load is less, so you will be definitely getting one newborn as a short case. So two examiners will be examining you based on your performance in newborn. So knowing, and a newborn is more of like an ocean. So questions, you can be asked questions from almost all parts in newborn care. So there is no specific like, will they ask this, will they ask this? And 2 hours of class also may not be enough. So it's just a start. You have to read more. Suppose the child has jaundice, then they will go in depth into jaundice. You have to prepare a lot of questions related to it. You have to prepare for phototherapy, for exchange transfusion, for etiology. So there is no end to the number of questions which can be asked in newborn. Actually, neonatology is a super specialty, no? So there is no end to it. So keep reading more, and it's a rewarding case actually, because definitely you will be given a case. So on the other hand, you will be reading 10 to 12 cases of different case scenarios, and here there is a short case, short you will get in it. So I expect you all to read it. Okay, Pavignesh, let's start.
Yes, sir. So a baby of Mrs. Kavita, who is a female, born on 30th October 2021, hailing from Kelambakam, whose informant is mother with good reliability, and the age at examination is 6 days, and the mother's age is 25 years, and period of gestation is 38 weeks, with obstetric score of P2L2 and a LMP of 16 January 2021 and EDD of 23rd October 2021, with blood group of mother, father, and baby, all are B positive, came to Tagore Medical College and Hospital. Next.
Okay. So the first slide is your demographic detail. So what all are you concentrating on the demographic detail, Vignesh? So when you...
Yes, sir. So I'm mainly concentrating on the age at presentation of this age at presentation. And so in this case, if the jaundice is presented within first day of life, then it must be most probably, or it is pathological. And if it is presented after 1 day or within 2 to 3 days of life,
that's not in the demographic. No. So demographic data, what are you concerned? So you want to know baby's name, which there will be no baby's name. So baby of mother's name. Okay. Then sex of the baby, like that. So what all you are going to ask? Sex of the baby.
Sex is
and,
female or male.
What is the day of life? Basically, what is the day of life? And what else you are concerned? Whether the baby is term or preterm, you can say no based on
yes,
the
sir.
date.
Gestational age. Yes.
So you are saying no gestational age. So based on that, whether term baby, preterm baby. Okay. And LMP EDTA, do you think it's like you have told how many days? No, 6 days. And the baby is born 5 days prior to the expected date. Like that, you can say.
Yes,
like, can you say it in a single line, this demographic data? So now you have written it, but while presenting, can you say it in a single line?
Yes, sir. So, baby of Mrs. Kavita, who is hailing from Kelambakam, with whose informant is mother with good reliability, and who is born 6 days prior to the expected date of delivery, came to Tagore Medical College with chief complaints of
6 days prior to expected data. Expected is 20, or now the baby is 6 days.
Yes, sir. Sorry, sir. 6 days.
So 6
after.
days old, 6 days old female baby of Kavita, 6 days old female baby of Kavita, born how many days prior to the expected date? So it might be 5 days or 1 week, born 5 days prior to the expected date. And it's being born out of a consanguineous or non-consanguineous marriage. Okay. So with the habitat status being P2L2. So like that, try to put it up in a single line, okay, before going on to the presenting complaints. Okay. 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 Next slide.
So, came to Tagore Medical College and Hospital with chief complaints of yellowish discoloration of skin since 2 days. History of presenting illness. The baby was apparently normal 2 days back, after which she developed yellowish discoloration of skin and eyes, which progressed from face till the umbilicus. And there is also a history of reduced passage of stool and urine along with inconsolable cry. There is no history of any aggravating or relieving factors, no history of any diaper staining or dark colored urine, no history of abdominal distension, no history of birth asphyxia, NICU admission, trauma, seizure, high-pitched cry, no history of poor sucking, abnormal posture, anemia or breathing difficulty, and there is no history of vomiting, delayed passage of urine or meconium, or passage of clay-colored stool.
Okay. So here, this is your presenting complaints. So yellowish jaundice. Jaundice is your presenting complaints. What else can be the presenting complaints? Usually we give a newborn. What else will be the presenting complaints?
So it can be any seizure, involuntary movements.
Okay.
Or in difficulty in feeding or poor feeding.
Difficulty in feed. Usually the presenting complaint might be the baby is feeding less. So that might be the presenting complaint, or yellowish discoloration of the jaundice, difficulty in feeding. Then what else? Usually for you, it might be a normal baby also. No? So normal newborn baby who is in the hospital because of maternal reasons. It could be maternal reasons. So there is no presenting complaint as such. The baby is here because of maternal reasons. The baby has yellowish discoloration of the skin, or the baby is not feeding well, or what else will be the complaints? And the baby is here because of prematurity and for feed establishment. That also can be there, no? So the baby is preterm. So usually you will be given a normal baby, a jaundice baby, or a low birth weight or preterm baby. Maybe sometimes there is a birth asphyxia baby who has recovered from it. So if there is any complaint as such, then you have to elaborate the presenting complaints. Or if the baby is a normal baby, healthy baby, then I think you can straight away go to your antenatal history. But here you have some complaint. So yellowish discoloration of the skin. So what all have you taken care in the history? What all you have asked to find out what actually here? Yellowish discoloration.
So since it has been presenting after a day of life, so it must be most probably a physiological jaundice. And I have also asked about the diaper staining or dark colored urine to rule out any cholestatic jaundice. And in order to rule out any inborn errors of metabolism or hypothyroidism, I have asked about abdominal distension. And and birth asphyxia is also a specific etiology for jaundice. So I have also asked that. And in case of any kernicterus, there may be high pitched cry, seizures, and any abnormal posturing like opisthotonus or arching. So I have also asked about this, not to rule out kernicterus. And in case of any pyloric stenosis or intestinal obstruction, there may be delayed passage of meconium, which in turn can cause hyperbilirubinemia. So I also asked that.
Okay, okay. So here you are saying that there is a jaundice. So how severe is how long? So one is duration. So how long the jaundice has been? So that's 2 days you are saying. So always start with what is the duration of the jaundice. Okay. Then what is the severity of jaundice? So what was the severity of the jaundice here?
Yes, sir. It is being distributed up to the umbilicus, sir, from face and up till the umbilicus. Okay. So according to the Kramer's scale, it corresponds to zone 2. Zone 2, so, therefore, approximately the bilirubin level must be about 6 to 8 mg per dl.
Okay, so Kramer's rule. So you should be knowing the Kramer's rule here. So jaundice from where to where. So what is the progression? So what is the duration, and how severe is the jaundice, and a differentiation between whether it is cholestatic jaundice or indirect hyperbilirubinemia. For that only, what all you have asked. So one is diaper staining and dark colored urine. Plus what else actually? So dark colored urine, diaper staining, and how will be the stools?
Stools will be clay colored.
Clay colored stools. So a differentiation. So, but I think that should be even below the history. Cholestatic jaundice is not common, but it's very important. So you put it down in the below. Okay. What else is very important? So what do you think are the common causes for jaundice? You said physiological, no?
Yes, sir. So it must be either breastfeeding jaundice or breast milk jaundice.
It must be breastfeeding jaundice. So what is breastfeeding jaundice? Breastfeeding jaundice.
So breastfeeding jaundice usually occurs because of when the baby doesn't receive enough breast milk, or there is inadequate breastfeeding from the part of the mother.
So that is the most common cause, right? So decreased feeding resulting in enterohepatic circulation, no?
Yes,
so that should be the commonest cause. Okay, then what else are the other causes? So have you asked in the history about regarding that feeding issues? Is there any difficulty in feeding? So I think when you elaborate, I think you have to ask such questions. So whether there is any problem with breastfeeding, okay, and what else did you think in the etiology other than breastfeeding?
Sir, it can be either due to sepsis, neonatal sepsis.
Okay. So any poor feeding, any lethargy, any dullness, so any fever, so
yes, sir.
like that. Okay. Anything else? Any swelling, cephalometoma, can that cause?
Yes, sir. Yes, sir. Cephalometoma can cause.
So any swelling in the head. So like that you can ask. So poor feeding, most important cause is poor feeding, and any swelling, any cephalometoma. How about prematurity? Can that cause jaundice?
Yes, sir. Prematurity can cause jaundice.
So those things, if possible, you can put it in the etiology. Then what else? So most important cause is what in addition to this? So blood group incompatibility is also possible, no?
Yes, sir.
So
I reckon.
mother's blood group is B positive, you said, no? So I
Yes,
think
sir.
here you can elaborate it. So trying to find out the etiology. Then comes the complications. So that's what you said related to bilirubin encephalopathy. So there is no poor sucking or abnormal posture or high-pitched cry and all, no? Okay, okay. So whenever you have a jaundice, there you are supposed to elaborate it in detail. So you start with how long the jaundice has been, since when the onset has been, as you said. So I think they will ask you questions related to what is pathological jaundice, what is physiological jaundice, no? The difference. Can you say the difference between pathological and physiological jaundice?
Yes, sir. So pathological jaundice usually presents within first day of life, and it
Okay.
persists more than 14 days.
Okay.
And the
Good.
total serum bilirubin will be more than 15 milligram per deciliter, and
Okay.
the rise in serum bilirubin will be 5 milligram per deciliter per day.
Okay.
And there may be a history of passage of clay color or dark colored urine or clay colored stools, and the direct bilirubin estimation at any time may be more than 2 milligram per deciliter.
Okay. So any direct bilirubin is also seen. I think you have picked up the point. So these questions they will ask you, how will you differentiate between physiological and pathological? So here is a 2-day child with jaundice. And then how is the severity of jaundice? You said up to chest as per the mother. You have to examine and say at present up to the chest the jaundice is there. Then you are going to try to find out some etiology behind this. So whether there is any poor feeding, whether there is any cephalometoma, whether there is any blood group incompatibility, or whether it is a cholestatic jaundice. So you are going to ask about diaper staining, dark colored urine and all. And finally, if is the jaundice really severe enough to have some complications leading on to bilirubin encephalopathy. Okay. Okay, continue.
Yes, sir.
So if it is a normal baby, then there will be no presenting complaints. If there are presenting complaints, then you have to elaborate the presenting complaints. So most common will be your jaundice. Then it could be the preterm baby who is there for feed establishment. Then you have to elaborate the baby was admitted in NICU, how the feeding was started, whether it was IV fluids, then was it NG feeds, gastric feeds, and then whether it was palliative feed. Now, at what stage is the baby with the feeding? So I think those things you can elaborate. So, and sometimes they will come with not feeding well. Mother is not confident, mother is not feeding well. Then you have to elaborate about the adequacy of the feeding, which we will discuss later on in the feeding history. If there is feeding problem, then you have to elaborate here itself. So if there is a complaint, you have to elaborate here itself. So demographic detail, presenting complaints, elaborate your presenting complaints. If there are no presenting complaints, then go straight away to your antenatal history. Okay.
Yes, sir. So antenatal history. So it's a booked case, immunized and pregnancy confirmed by urine pregnancy test. First trimester, the birth order of the child is second. There's no history of any fever with rash and lymphadenopathy. No history of excessive vomiting, fatigue, radiation exposure. No history of any drug intake. No history of burning micturition, increased frequency of micturition. No history of bleeding or leaking PV. Dating scan was done. Folic acid tablets were taken, and there is no history of any blood transfusions.
Okay, so this is first trimester. So these are all standard questions, which your standard history pattern, which you are going to ask. Vignesh, can you say what are you concentrating in first trimester?
Yes, sir. So I'm asking about fever with any rash or lymphadenopathy because in order to rule out any torch infections,
okay,
and history of excessive vomiting to rule out any hyperemesis gravidarum or any radiation exposure which can affect the fetus in utero. And
okay,
if there is any history of any drug intake, which may act as teratogens and can affect the baby.
okay,
and history of any burning micturition or increased frequency of micturition to rule out any urinary tract infection. And for determining the gestational age, I'm doing dating scan, and folic acid tablets I'm giving in order to prevent neural tube defects in the child.
So what
And,
is this leaking PV?
sir, like spotting, sir.
Spotting. So then spotting, I think leaking is specific for amniotic fluid, no? So at first trimester may not be so correct to say leaking PV. Okay. And why blood transfusion? Why are you worried about blood transfusion? No history of any blood transfusion in first trimester.
Sir, in case of any mismatched blood transfusion, it can cause any intravascular hemolysis in the mother.
Don't worry. Okay. So whenever one more important point is whenever they ask something, do not say some. If you don't know, you don't know. Sorry, sir, I didn't mention.
Sir.
Don't go into far-fetched to substantiate your point. You understand? To substantiate your point, do not go to that extreme. No. So no history of any blood. I don't think it's relevant here. Blood transfusion for a first trimester. Okay. So first trimester, what are we concentrating? So whether the mother is a booked case or not, so that the care is there or not. So adequate care and trying to pick up the complications, whether that thing has happened or not. So that we are very much bothered. So I think you have covered that, booked. So the mother is a booked case. Okay. Pregnancy confirmed by UPT. I don't think it's okay. You are saying it in a routine. You are saying pregnancy confirmed. That's okay, fine. But most important is it a precious baby? So I think that will be a very important point. No. So how did the baby was conceived? Whether they did any artificial reproductive technique and all, no? So in vitro fertilization, anything was done special after a long period of infertility, then there is a chance that this baby also may have complications. So those questions you can ask, but most important is first trimester is the period of what? First trimester is the period of organogenesis. No, first trimester is the period of organogenesis. Yes. So club up to your questions related to organogenesis. So I think you have done it right, but maybe clubbing would have been better. In between, you have asked excessive vomiting, so that you will remember nicely. So fever with rash and lymphadenopathy for torches, accidental radiation exposure, and no history of any drug intake. Okay, so those three questions will be your clubbing for organogenesis. Then your hyperemesis, fine. Then threatened abortion, fine. And folic acid, fine. So they might ask you no questions like what are the drugs that can cause teratogenicity? Some 4 or 5 drugs you should be knowing. Can you say, Raghu? Can you say few drugs that can cause
lithium, which causes Epstein anomaly, and iodine, which may cause fetal iodine syndrome.
Phenytoin, fetal iodine. Okay.
And valproate may cause neural tube defect.
Neural tube defects, cleft palate. Okay. Then you have alcohol also, fetal alcohol syndrome. Tetracyclines can affect the bones, no? Tetracyclines. Then antithyroid drugs can affect the thyroid, hypothyroidism for the baby. So some few drugs are older, thalidomide, but I saw one examiner got irritated with thalidomide, but thalidomide was the mother of all teratogen which brought into it. But nowadays we are not using it, so do not straight away go with thalidomide causing phocomelia and all. Maybe at the end you can keep it. Okay. So that's fine. Then next is your dating scan. You are going to assess the gestational age. Plus, at the end of the trimester, do you do some Downs screening, Vignesh?
Yes, sir.
So what is that?
Nuchal translucency.
Nuchal translucency scan. You can add a point on that, nuchal translucency. Then folic acid, any dosage you know of for what dosage we give?
Sir,
you know of
400 micrograms.
Enapa?
400 micrograms.
400. Okay, 400 micrograms. If there is a previous sibling with neural tube defect, then what is the dosage?
4 to 5 mg.
4 mg.
Then it becomes 4 milligram. Okay. So the basic stuff only. I'm just asking you so that all understands those. And these basic steps, if you are through, I think you are through with your, you will pass. So that's what I'm concerned. Okay. So don't say anything I don't know and all. No? So folic acid, and we don't give iron here. No. vomiting and all going on. Okay. Okay, pa. Second trimester.
Yes, sir.
Ha,
So second,
Naveen has answered aminoglycosides. Hearing, it affects the hearing. So that is also a teratogen. Good. You can add it in the chat box. Actually, it's coming in the chat box, or you can raise your hands and
Mnemonic
also.
is safe, sir. S for streptomycin, A for
Uh-huh.
aminoglycosides, F for phenytoin, E for ethanbutol.
Ethambutol. Ethambutol, any specific teratogenicity you know of? Okay, so I think having a mnemonic also is fine. So at least 5 drugs you should be knowing. Okay, okay. Second trimester.
second trimester, quickening is felt at 5th month of gestation. Iron, folic acid, and calcium tablets were taken. Next.
Okay.
Anomaly and nuchal translucency scan were taken and were normal. Mother is immunized with 2 doses of TT vaccine at 4th and 5th month, and there is no history of any gestational diabetes mellitus or pregnancy-induced hypertension.
Okay, so second trimester, what you are concerned about?
Sir, I'm concerned about I'm taking anomaly scan in order to rule out any congenital anomaly present in the baby.
So that's around usually around 20 weeks. 20 weeks. You do the anomaly scan. Okay. Okay.
Yes. And I'm also assessing whether the mother is able to feel the first fetal movement.
So that is quickening.
Quickening.
Okay, good. So when you perceive the quickening movements, okay.
And a mother is immunized with 2 doses of tetanus toxoid vaccine.
Okay. And the iron and folic. So we start supplementing the iron and folic acid, and the complications specific to pregnancy starts happening here. So that's why you are asking about PAH and gestational diabetes mellitus. Okay. So quickening, suppose what is the relevance of quickening? Suppose there is less fetal movement, what might be the significance?
It may be due to polyhydramnios. The amniotic fluid is more.
Okay. Okay.
And in case of any IUGR, there may be less fetal movements.
Okay. So IUGR. No? So basically any hypoxia, no, any asphyxia, any hypoxia, the baby is in distress. So the baby's fetal movements might be less. And rarely, suppose the child has muscular problems, no, spinal muscular atrophy and all, no. So then they are prone for decreased movements. So quickening is about that. And then you have the anomaly scan, quickening, then complications related to pregnancy, GDM and PAH, then immunization with TT vaccine, then the liker. How about oligohydramnias and polyhydramnias? Okay, can you tell of any congenital abnormality that leads to polyhydramnias or oligohydramnias, Vigneshwar?
Not sure, sir.
Okay, so basically it's about the drinking of the amniotic fluid and passage of urine that contributes to the amniotic fluid. Okay, so if the baby has some abnormality in the esophagus, what will happen to the amniotic fluid? So you can get polyhydramnias. No, so if there is esophageal atresia, so you can get polyhydramnias. Similarly, if there is a bilateral renal agenesis, no, severe renal agenesis, you will end up with what? Oligohydramnias. So the urine is not contributing to the amniotic fluid, oligohydramnias. And because of that, there is no space and the baby gets compressed, and no, the Potter's sequence. The Potter's sequence is because of the oligohydramnias. So those things, okay. Okay, pa. So third trimester.
Third trimester, the history of fetal movements perceived. Iron and calcium tablets were taken. There's no history of bleeding, PV, abdominal pain, or swelling in lower limb, which is not subsiding with rest. There's no history of any burning, micturition, or increased frequency of urination. Growth scan was taken and found to be normal, and the total weight gain during pregnancy is 12 kgs.
Okay, so third trimester, what we are concerned?
So we are concerned about the growth of the fetus, sir.
Growth of the fetus. So
Fetus.
growth scan. So you want to make sure that the baby is growing very well or not. So you have a growth scan there, and make sure that the iron and calcium tablets are continued. Okay. So how many days we usually, as per community medicine, no? So we give for 100 days, no?
Yes, sir.
100 days of iron. Okay. And the complications, mainly the complications, make sure the complications are they worsening, whether the PAH is it worsening, is the GDM worsening. Okay. So the swelling in the lower limb, no? So whether the edema is increasing, whether the headache, blurring of vision, any seizures, no, whether the complications are worsening, and whether there is any premature labor onset going on. So whether there is any leaking per vaginum, whether there is any abdominal pain, no. So whether there is any chances of premature delivery happening. So those history you can ask, plus any infection, any threat, no. So that can directly affect the baby at the time of birth. So early sepsis. So early onset sepsis might have relevance to the mother's problems. So that only you're asking, that's why. No history of burning micturition, increased frequency. So make sure that whether there is any UTI is there or not. And then foul smelling liquor or lower abdominal pain, no. So that is suggestive of what? Foul smelling liquor, fever, lower abdominal pain, suggestive of chorioamnionitis. So chorioamnionitis, UTI, any fever, anything, no. So at the end of the third trimester, that can have a direct bearing on the well-being of the baby. So early onset sepsis, probably the organism has come from the mother. So that history you are trying to take, and finally make sure the total weight gain is around at least 11 kg. 11 kg, no. Okay. Seripa. Next.
Yes, sir. Natal history. So it is a full-term baby, birth weight of about 2.7 kgs, born out of normal vaginal delivery at Tagore Medical College and Hospital on 30th October 2021. So a live female baby weighing 2.7 kgs was delivered in vertex presentation by normal vaginal delivery at 8 a.m. on 30th October in the labor ward of Tagore Medical College.
Okay, pa. So in the natal history, what you are going to ask actually?
Sir, regarding whether the baby is term or preterm, and regarding whether the baby's birth weight is, whether the baby is low birth weight or appropriate for appropriate birth weight, and whether the baby is born out of normal vaginal delivery or any LSCS was conducted or any forceps delivery was done. And
okay.
So for place of delivery, in order to ensure whether the delivery was conducted by trained DICE or
Okay.
any. Yes.
Okay. So and how was the labor period? No. So we want to make sure whether everything went well. Okay. Whether there was any prolonged labor. So what was the labor duration? I think that you could have added anywhere you have mentioned like labor pain started and the baby was delivered. The total duration of the labor was so make sure that it is not more than 18 to 24 hours. Then it becomes a prolonged labor. So then there is a risk of asphyxia, hypoxemia to the baby. So what is the duration of the labor? So that one point you can ask. Then as you said, any assistance was needed, whether it was vaginal delivery, whether it was forceps or any suction was used, or whether you had to go for LSCS. If you have gone for LSCS, you have to mention the indication, whether it's an emergency LSCS or it's an elective LSCS. Emergency, what was the reason for the emergency LSCS? So we want to make sure whether everything went well or not, and whether there was any insult to the baby, whether there was a hypoxemic insult to the baby. So that we are more concerned, plus as well as any chance of infection that can happen. So if you have a prolonged labor, you have done more pervaginal examination and all, no, so premature rupture of membrane, so the bacteria can go to the baby. So there is a chance of infection also. So that also you can elicit. And finally, you are seeing the baby was, what was the birth weight of the baby? What was the weight? 2.7 kg. And whether, okay, that you are saying it in the postnatal history. Okay, so anything else you want to mention in natal history, Raghu? Okay. So postnatal?
Yes, sir. Postnatal history. Baby cried immediately after birth. The breastfeeding was initiated within half an hour of delivery. There's no history of any NICU admission. No history of any yellowish discoloration of skin and mucous membrane within 24 hours. There's no history of any delayed passage of urine or meconium or any diagnosis of congenital anomaly.
Okay. So in the postnatal history, we should make sure that the baby cried immediately after birth. So that is the first initiation of the breath. No? So whether the baby, if the baby has not cried immediately, whether any assistance was given. So whether any initial steps of resuscitation was given. So here they might ask you questions related to NRP. Can you tell the initial steps of resuscitation, Vignesh? So what will you do? Suppose the baby is not cried.
Yes, sir. First, we'll be assessing whether the baby has cried or not, or whether the baby is term or not, and the tone of the baby, sir.
Okay, very good.
And then, and after that, if any of these three is not normal, then we'll be
so any one of the three is
yes,
no. Then you are going to give the initial steps. Okay. So what are the initial steps of resuscitation you do?
So first, we'll be determining the heart rate and the respiratory rate.
We don't go to the heart rate straight away. So initial steps. Raghu, can you tell the initial steps of resuscitation?
So first, we have to maintain the temperature. Then we have to go for airway. We have to check for. We have to position the airway. Then breathing must be checked, and then if we will clear the secretions if any present.
Okay. Okay. So that's the initial steps. For before we are not going to check the heart rate and respiration straight away. So that will be at 30 seconds. So what you said was very good. The three questions: whether the baby is term and or preterm, whether the baby cried or not, and how is the tone, whether the tone is good or not. So if anything is not correct, any answer is not correct, then you go for the initial steps. So in the initial steps, as he said, you receive under warmth, so that will be the temperature. Then airway, so you suction out the secretions. Mouth will be suction first, then the nose, so that will be the removal of the secretions. Then the breathing. So for breathing, what is the most important stimulus for breathing? Vignesh, what is the most important stimulus for breathing? Just drying the baby is the most important stimulus for breathing. So you dry up the baby, and still if the baby is not crying, then you are going to rub the back and lightly tap the sole, gently tap the sole, and then only you go for the measurement of the heart rate. If the heart rate is less than 100, then you go for positive pressure ventilation. So definitely they will expect you to know if at this point what is the NRP protocol, how will you resuscitate if the baby, even examiners have asked, have you not gone to the labor, have you not seen any baby delivered, like those questions. So if you're going to say the protocol, they're going to leave you at least the initial steps till you give bag and mask ventilation. So if the heart rate is less than 100, I'm going to give bag and mask ventilation. So make sure the baby is cried immediately after the birth, and after that whether the breastfeeding was initiated or not. So breastfeeding has to be initiated as early as possible. So that's not half an hour and all. It has to be as early as possible, and make sure the baby is not in NICU for any other reason. So any reason for which the baby is admitted, then you have to mention those things. And regarding this passage of meconium, Vignesh, what is the cutoff? How long, how quickly the baby should have passed meconium or urine?
So within 24 hours of birth.
So meconium and urine 48 hours. Suppose the baby has not passed meconium within 24 hours, what will you think of? Vignesh? Raghu?
Yes, sir.
Sir, can you repeat the question, sir?
Suppose the baby has not passed meconium within 24 hours. Then what is your thought process? Anybody wants to discuss? Very important, actually. They will expect you. So within 24 hours, if the baby has not passed meconium. So if the baby has passed meconium from the second part of the duodenum till the anus, there is no major congenital abnormality. So there is no major atresia. That's why the baby has pars meconium. If the baby has not pars meconium, then we should be worried whether there is any major anomaly is there or not, whether there is any atresia, whether there is any, it could be just an anal atresia. You should have seen the anus. So whether there is any anal atresia is there or not, and whether it could be a higher anorectal anomaly, or it could be a Hirschsprung's disease where the rectum, aganglionosis of the rectum, so the baby has not passed stools. So if the baby has not passed meconium, it's a cause of concern. Are you dealing with some congenital atresias and anomalies that is preventing the meconium to pass, or Hirschsprung's disease? No, so that is important. Okay, and urine also same. The baby should have passed urine within 48 hours, if not some major obstruction in the urogenital tract you are thinking of. Okay, next, breastfeeding initiation. So I think here breastfeeding initiation, so they will ask you about I think you are coming down, no? So prelacteals next.
Yes,
Okay,
sir.
go on.
Next slide. Feeding history. Breastfeeding was initiated within half an hour of delivery. Number of times during day, the baby was fed on demand, approximately 5 to 6 times, and during night about 2 times. No prelactal feeds were given. No complementary feeding was done. The baby used to pass urine 4 to 5 times per day, and the baby used to pass stools 3 to 4 times per day. And the baby sleeps for about 1 hour after feeds and wakes up crying.
Okay, so what they will expect you of breastfeeding is, you have nicely said initiated early, and it should be demand feeding. As you said, it should be demand feeding, and it can be many number of times. No, instead of this 5 to 6 times, it could be more than that. Okay, that's okay. Then nighttime feedings, I think it's a bit less. So usually babies are awake in the nighttime and they'll be feeding more number of times. So it might be a bit on the lower side, I would say, the feeding. And no prelacteal feeds, I think good, no prelacteal. What is this complementary feeding? I think the term you're miss complementary is something we use it after 6 months, no? The weaning foods. So no history of any artificial food supplements, you're saying, no?
Yes, sir.
Milk substitutes. So no using of any
Formula.
milk substitutes, formula feeds. It's exclusively breastfed. So the baby is being exclusively breastfed. And here comes the question. So here you also said, no, initially in the presenting complaints, the baby is passing less number of urine. So here I think that might be the reason, no? So less number of urine. So
Yes,
you have to further probe into the adequacy of feeding, and the attachment and positioning. How will you ask questions related to adequacy of feeding?
yes, sir. So I will ask whether
In addition to these, I think here the number of feeds, number of times the passing urine. So I think somewhat you have picked up. What else you can ask for adequacy of feeding?
So whether the baby sleeps for about 2 to 3 hours after feeds.
Okay.
And whether it passes urine about 6 to 8 times after feed.
Okay. So here it's a bit less, no?
Yes, sir.
And sleeps, and the baby is crying more fuzzy. Okay. And how long the baby is feeding each time? So if the baby feeds only 5 minutes, no? So maybe it's less. Okay. Then what else? How will you say the adequacy of feeding? How about the mother's adequacy? How will you say that mother is having enough secretion?
So if she is not confident about
So one, and after feeding is is there breast engorgement? No. So usually after feeding, is there any lightness of the breast? Does she feel that? Subjective feeling is important, and dripping of milk. Sometimes baby feeds on one side, the other side you will have dripping of milk happening. No. So that all suggestive of adequacy of feed. So the baby feeds often, the baby passes urine well, and the baby sleeps well, and the mother feels that milk gets emptied, and mother feels that milk overflows on the other direction. All these are adequacy of feeds, and the proper attachment. What do you know the points related to proper attachment of feeding?
Yes, sir. So the baby's mouth must be wide open and it must be covering almost the full area of nipple and areola.
Okay.
And the baby's chin must be touching the mother's breast.
The lower lip must be
averted.
Very good. So many times the parents are not doing it. Most often the mothers don't know this, and they often give only nipple feeding rather than the areola, and they end up with poor feeding. The baby doesn't get much of milk, and most often whatever you are dealing with is that only. So the baby's jaundice is more because of poor feeding. So the baby is not getting enough milk. What happens when there is not enough milk? Why does jaundice happen when there is not enough milk? Because there is a relevance to here, no? So the baby is having jaundice with no blood group incompatibility. So baby's blood group is B positive, mother's is B positive. So what is the relevance with jaundice and poor feeding?
So because of poor feeding, there will be decreased gut motility, sir. So because of which there will be increase in the enterohepatic circulation of bilirubin, which in turn causes jaundice. Hello?
Hello, sir. We can't hear you, sir.
Hello, able to hear?
Yes, sir.
Okay. So what is breast milk jaundice?
Yes, sir. So breast milk jaundice usually occurs after 3 to 4 weeks of life. And it occurs mainly due to the substances that are present in the breast milk. Which,
inhibitory substances.
yes, sir,
Okay.
inhibitory substances.
So the usually second week. From the second week, you start having the breast milk jaundice. Okay. Okay, pa. So the feeding history, I think very important. They will ask you, you have to be more probing about the adequacy of feeding, about the proper attachment, about the, then finally the weight gain. I think weight gain also you can put up here. Any idea about what has happened to the weight over the past 6 days, Vignesh, from the birth weight?
Yes, sir. It has reduced by 0.2 kgs. Today's
So
weight is about 2.5 kgs.
200 grams, huh?
Yes, sir.
So 200 grams, is it acceptable? So the baby's weight loss pattern. So they will ask you weight loss pattern. So how much do you expect maximum significant weight loss? When will you say significant weight loss? Baby's birth weight is
2.7.
2.7. So what is significant weight loss?
If it is more than 8 to 10% of its
8 to 10%. So more than 8 to 10%. So somewhere around 250 grams. So I think 200 grams is fine. So the baby has not. But most often these babies, no. So the jaundice, mother not confident, poor feeding, child excessive crying. No, when you look into the weight pattern, there will be a significant weight loss. It will be 300, 350 grams. So it is all boils down to poor feeding. So most often it will boil down to improper breastfeeding, mother not confident of feeding. No, so correcting those things will help you improve up the problems. Okay, okay. Continue with the immunization history.
Immunization history: the baby is immunized with BCG, OP1, hepatitis B vaccines.
Okay, so that will be your birth vaccines. So they might ask you about the route of vaccination. I think you will be telling it intradermal BCG live vaccine. No, so basic questions they might ask you. So they might ask you the progression of BCG. So sometimes they might ask you here. Okay, okay, continue. Suppose if mother is hepatitis B positive.
So we'll be administering along with immunoglobulin, sir.
So you have to give hepatitis B immunoglobulin in the other thigh. In addition, at birth, vitamin K. We will be giving vitamin K. Vitamin K. And breastfeeding, breast milk. So what are the nutrients which are deficient in breast milk?
So vitamin D.
Okay.
Vitamin D
which we supplement. Anything else? Vitamin K. So that's why we give vitamin K. So vitamin D, vitamin K. Anything else which is insufficient? Iron is a bit insufficient, but till 4 months it's adequate. The bioavailability is good, but beyond 4 months it's not enough. You have to supplement iron beyond 4 months of life. Okay, okay, but continue.
Next slide.
One minute, sir.
So you can keep telling. So where were we? We were in the feeding.
Immunization histories.
Immunization. Then afterwards, marital history and
Yes, sir. Socioeconomic history.
okay.
So the family belongs to a lower middle class, class 3, according to modified Kupuswamy classification, and class 3 according to BG Prasad classification.
I think one is enough. Any one. Pediatricians are not well versed, so Kupuswamy is very common, no?
Yes.
So you do that. Okay. Then
in family history, there is no history of any hemolytic disease in the family. There is no history of any liver disease, disease of gallbladder, or any hereditary disease in the family.
okay, why you are specific about hemolytic disease? No? Commonly you say no history of any hereditary disease because of the jaundice. No?
Yes, sir.
Okay. So commonly no history of any significant familial histories. Okay. Gayatri ma'am. Continue.
Yes, sir. Then marital history. So it is a non-consanguineous marriage, married since 1 year, and the mother age at marriage is 24 years. There's no history of any infertility treatment, and there is no history of any miscarriages.
Okay, so no history of any infertility, miscarriages, but this is para to live too, no?
Yes, sir.
So how about the previous sibling? What has happened to the previous sibling?
So the previous sibling is normal babies. There's no history of any jaundice in the previous sibling.
Konjo, we have to more detailed about the previous sibling. You have to add. So what has happened to, what is the age of the child? Antenatally and perinatally, any issues with that delivery the mother has to face. So those details you can add it in the marital history. Okay.
Yes.
Okay. Gayatri ma'am. Good evening, ma'am. Madam has joined. She is assistant professor in SRM Medical College. Okay, continue. Some screen problems are going on, I think. You can present?
Yes, sir, I will try.
Okay. So next.
Yes, sir. Summary. So a 6-day-old term baby girl who is immunized till date, born to parents of a non-consanguineous marriage by normal vaginal delivery, with birth weight of about 2.7 kgs, cried immediately after birth, came with complaints of yellowish discoloration of skin since 2 days, associated with reduced urine output and inconsolable cry with no other significant antenatal or perinatal issues.
Okay, pa. So here in the summary, who is immunized till date? Only one immunization only
Yes,
given.
yes.
No?
Yes.
So till date, no?
Okay,
Who
sir.
has been immunized with birth vaccines, born to parents of non-consanguineous with a birth weight of 2.7 kg, cried immediately after birth, came with complaints of yellowish discolor, came with complaints of, you can straight away say jaundice for the past 2 days with poor feeding and reduced urine output and inconsolable cry. So probably hunger cry or you have to evaluate that. No? So what is your probable diagnosis? Probable diagnosis for the jaundice here.
So probable diagnosis, it must be either breastfeeding jaundice
Okay.
or any neonatal sepsis.
Okay. Because of the inconsolable cry and poor feeding. Okay. So we have to evaluate for that also. Okay. Nice that you have given a differential diagnosis. So it could be just a poor feeding and breastfeeding jaundice, or it could be some major issue with the sepsis. It could be sepsis as said by you. Okay.
Yes.
Gayatri ma'am, are you there? I think some issue with her. Okay, we will continue. Summary. Good. Next.
Yes. General examination.
Actually, ma'am cannot mute. It says. Wait, I will try to. Ma'am, can you unmute? Good evening, ma'am. Good evening. Gayatri ma'am is assistant professor from SRM Medical College. She will also continue and add to the discussion. Okay. Okay, ma'am. Okay. Ma'am, we have finished history, ma'am. We are in general examination, ma'am.
Sure, sir. Okay, sir.
Okay, pa. Continue, pa. Vignesh.
General examination. Term newborn baby girl who is awake with posture and attitude. There's complete lack of head control, straight back with elbow and knees flexed with slight extension at hip. And in prone position, the head is turned to one side and the pelvis is high. In supine position, asymmetric tonic neck reflex is present. And there is no history, no pallor, and icterus is present. There's no cyanosis and no edema. Vitals.
Okay, pa. So general examination, you're saying first is your sleep state. So conscious oriented, we say, no? So that is awake.
Yes.
So here the baby is awake. Stage of awakefulness, you can say. So do you know of the stages of awakefulness?
Not sure.
Right. So if you are able to say the Pritzel stages, no, stage 1, stage 2, the baby is sleeping. So deep sleep stage 1, stage 2 will be REM sleep. Then stage 3 will be awake but quiet. Then stage 4, the baby will be awake with some active movement, and stage 5, the baby will be actively crying. So here usually the ideal stage for examining will be your stage 3. So the baby is awake and not moving much. So usually that will be half an hour to 1 hour after feeding, no? So we get such a stage. So here the baby is awake, and you talk about the posture. I think for a UG level, if you are just saying what is the posture, that's enough rather than going too much into say like complete lack of head control. So usually we don't expect head control, no? So you just say all the four limbs are actively flexed. So what is the basic posture you're looking into? So all the four limbs are actively flexed, or if the baby is a bit preterm, the legs are a bit extended, no? So the flexed posture will not be there. So the tone will be on the lower side. So you will not have the flexed posture. So whatever is the posture, if the baby is too much preterm, you will have a pithed frog, no? So the legs will be a bit extended. So the posture as a whole, you can say, rather than saying how is in the prone, ventral, supine, no? So I think for PG discussion, that's fine. For UG level, what is the state of awakefulness? Stage 3, breath cell stage 3, awake. Then posture, the baby is having in a flexed posture and moving all the four limbs. and activity is reduced. So you want to say that the baby is sick, right? Activity is reduced, sepsis, no, Vignesh?
Yes, sir.
Okay, but usually in exams, we usually don't give you sick kids, okay? So actively moving all the 4 limbs, or if there is any asymmetry in the movement, that you can tell, okay? Then your icterus, pallor, cyanosis, edema. So here you have said the Kramer's zone, icterus is present. I think good. So Kramer's zone you are elaborating here, okay? Ma'am, anything else you want to add, ma'am, in general examination?
So can you hear me?
Yes, ma'am. Yes, ma'am. Able to hear, ma'am. Some issues. Who host? Cheripa, vitals, you move on, pa. Vitals.
Yes, sir. The pulse rate, it's 142 beats per minute, which is regular in rhythm and normal volume and character. Temperature is about 98 degrees Fahrenheit. The respiratory rate is about 42 breaths per minute, and the capillary refilling time is less than 3 seconds.
Okay, so what is your interpretation of the vitals?
So the pulse rate normally in a newborn, it must be about 160 beats per minute, and
110 to 160.
Yes, sir.
Okay.
And here it is 142, so it is in normal range. And the temperature, it must be about 36.5 degrees Celsius to 37.5 degrees Celsius.
Okay. Okay.
And the respiratory rate should be about 40 breaths per minute.
So, so when will you say tachypnea?
So it must be more than 60. Sir.
So when it is more than 60, it is tachypnea. Then capillary refilling time. So that should be less than 3 seconds. So for a good perfusion. So questions there in vitals, they will ask you a lot of questions. So what is bradycardia? What is bradycardia in the newborn? So in your NRP, you start giving positive pressure ventilation, no? So what is that heart rate when you start giving positive pressure ventilation?
So if it's below 100.
100. So for 100 for us, it's normal, no? So for newborn, anything below 100 is bradycardia. Okay. Similarly, for temperature, when will you say it has cold stress?
So if it's between 36 degrees Celsius to 36.4 degrees Celsius.
36.4 degrees. So cold stress. So if you leave unattended, the baby is going to go even hypothermic. So anyway, to clinically say that the baby is in cold stress, how will you clinically say instead of measuring? The baby is in cold stress?
Sir, by feeling the temperature in the extremities. Sir.
Okay, so extremities will be cold, but center will be
warm.
So that is cold stress. So then you have a moderate hypothermia and severe hypothermia. So 32 below is your severe hypothermia. Then tachypnea, they will ask you what is fast breathing rate, then capillary refilling time, and blood pressure. You cannot measure, but they might ask you what is the normal blood pressure in newborns. What is the normal blood pressure in newborns?
So it is about 60/40 mmHg.
So it is half our blood pressure. Half our blood pressure will be your normal blood pressure. Okay. Gayatri ma'am, you are there, ma'am. You want to add anything?
Yes, sir. Apart from that, they will ask where do you see the character of the pulse and all, and where do you see the edema in the newborn?
Edema in the head to foot examination. Vignesh?
Yes, sir.
Ma'am asking, where will you look for edema in the newborn?
Sir, in the pre-sacral region will be.
Sacral area. So dependent edema is in the sacral area. How about the volume character? Where do you check for volume character of the pulse? Sorry.
Not sure, ma'am.
It's actually in the brachial and the femoral. Not used to check in the carotids, but in the newborn it is brachial and the femoral. Okay.
Okay, ma'am.
Okay, ma'am. And most important is whether all the pulses are palpable, especially the femoral. So what will you think of if the femorals are not feebly palpable? What will you think of in a newborn? Vignesh?
Yes, sir. So, sir, any coarctation of aortas?
Okay,
Abdominal aorta.
most important one is your coarctation of aorta. So make sure your pulses are felt well, especially the femoral pulses. It's not feeble. Okay. Okay, but continue to the next.
Yes. Next.
So can you, 1 minute, sir, there is a network issue.
Anthropometry. Continue.
Birth weight is 2.7 kgs. The today's weight is about 2.5 kgs. Length is about 50 centimeter. Head circumference is 34 centimeters and chest circumference is 32.5 centimeters.
Okay. Ma'am, anthropometry, what you want to ask, ma'am?
Actually, what is the day of date of birth or
No,
something?
6th day,
What
ma'am.
is-
No.
6th day, okay.
6th day, ma'am. No.
They will ask only the normal parameters and the ponderal index. In the case of IUGR and symmetrical, asymmetrical, ponderal index is important to know whether it's symmetrical. Apart from that, the
Ponderal
normal
index,
values.
Vignesh.
Yes, sir. So it is
Ponderal index.
weight in grams into 100 divided by cube of length in centimeters.
Okay. So what is your interpretation? If it is less than 2?
So if less than 2, it is IUGR, sir.
IUGR da, but difference between asymmetric and symmetric IUGR. That's the ponderal index. So if it is less than 2, it is asymmetric
Asymmetric
IUGR.
IUGR.
If it is more than 2, then it is symmetric IUGR. Okay. Then in birth weight, they will ask you so basic stuff. So what is low birth weight? What is very low birth weight? What is extremely low birth weight? Okay. Vigneshwar?
Yes, sir. So low birth weight is less than 2.5 kgs.
Okay.
And very low birth weight is less than 1.5 kgs and extremely low birth weight is less than 1 kg.
Okay. So the basic stuff, many students are not even saying that. So what is extremely low birth weight? What is low birth weight? No. What is very low birth weight? Then what is SGA and LGA? What is the definition for that?
Yes,
SGA, LGA.
So SGA is small for gestational age. If the weight of the infant is less than 10th percentile,
Okay.
normal. And large for gestational age is if the weight of the infant is more than 90th percentile.
Okay. So what growth charts will you use for plotting all this? Will you take and go growth charts? Then only you will know, no, whether it is less than 90th centile,
Yes.
less than 10th centile. Do you have any specific growth charts? Ma'am, is it the same intergrowth 21 only, no, ma'am? We are following
I'm sorry, sir.
the growth charts, intergrowth 21 charts.
Yes,
That only we are following.
yes, sir.
No?
Only for the IUGR we use this Phantom or something. Otherwise,
Okay.
normally this only preterm we use the Phantom. From the intrauterine growth, we'll measure it.
Okay.
Otherwise, this same only, sir.
Okay, so you should use proper growth charts. So intergrowth 21 chart you can use, and whether it is less than 10th centile or not. Then they will ask you the regular definitions for head circumference. No, so microcephaly. Microcephaly is how much standard deviation below?
So less than 3 standard deviation.
Okay, very good. So less than so basic stuffs you are knowing. So good. And at birth, you expect the chest circumference to be lesser than the head circumference. When does it cross the head circumference, chest circumference?
After 1 year.
After, so around 9 months it process, and you should know what is the instrument for measuring the length and all, no? So the infantometer. Then they will ask you the weight loss pattern. So the baby is born, no? So you said we already discussed 10% weight loss, and then the baby gains the birth weight by what day of life, Vigneshwar?
By about
So the
10
baby
days.
by about 10 days, and for preterm it might be even up to 15 days. So that significant weight loss. So initially weight loss. Then after that, the baby starts gaining weight by how much? Every day the baby gains weight by
30 grams.
30 grams. Okay. Then head circumference also, how does the rate of increase in head circumference, they will ask you. So initially 2 centimeter first 3 months, then 1 centimeter per month. So anthropometry, a lot of questions can be asked. And what is the ideal time for measuring the head circumference? So birth weight you measure at birth. Head circumference, when do you want to measure? Do you want to measure it day 1, Vigneshwar?
Not sure, sir.
Okay. So initially you have molding happening, no? So the baby is born through the vaginal tract. So molding is happening. So the head may not be in the correct shape because of the molding. So ideally you should give some time. So maybe 2 to 3 days time before measuring the head circumference. So straight away you measure on day 1, you might have all the overlapping of the sutures, no? So it's not the ideal time. Okay. Then head to foot examination.
Yes, sir. Scalp, the hair is present normally. There is mild overriding of sutures present. Head, the anterior fontanelle is open of about 2 cross 2 centimeters, which is flat and slightly sunken. The posterior fontanelle is open, measuring about 1 cross 0.5 centimeters, which is soft and slightly sunken. Symmetrical face with no signs of any birth trauma, no cephalohematoma and or caput succedaneum. Face, there's yellowish discoloration of face present, no dysmorphic facies. Eyes, there's yellowish discoloration is present.
Okay, wait. Ma'am, you want to add anything? We'll do. Because head to toe examination is the most important part of examination in newborn. Okay, the RS system, CVS, you may not have much findings. The head to toe examination is very important. Ma'am, you want to add anything? Yes.
Yes, sir. In the fontanelle part, whether it is pulsatile or not pulsatile, it has to.
Okay, ma'am. Okay.
Apart from that, yes, sir. If you are mentioning as no dysmorphic faces, what type of dysmorphism you are going to expect in this child? Otherwise, you can just leave off like not even mentioning the no dysmorphic faces. If examiner asks you, then you can say that I saw. What is your expectation? I just wanted to know what is your expectation, what the child will have as a dysmorphic faces.
What will you look for? What will you look for? Dysmorphic faces. Vigneshwar?
Yes, sir.
Dr. Vignesh?
So dysmorphic faces and regular. So usually for your level Down syndrome, you remember. So what all dysmorphism you look for in the faces? So low set ears.
Low set ears. Yes,
low set ears. Any mongoloid slant is there or not? No. So like that only you will look for. Hypertelorism.
Any puffiness is there?
Puffiness. For what part dysmorphism?
So if there is any hypothyroidism or any condition.
Okay, but you will get a lot of things, but I think no dysmorphism is fine. For your level, if you say what all dysmorphism you look for, Abdinaka, you remember Down syndrome. So no history of any low set ears, no any hypertelorism, epicanthal fold, no mongoloid slant. At least that much you should be able to say. Okay. Then, but basically we are more concerned about any subtle congenital abnormalities. So one is dysmorphism and the other is congenital abnormalities. So any abnormality in the face, eyes, ears, it could be a preauricular tag, it could be a preauricular sinus, it could be a cataract. So anything you are there, it should be mentioned in the head to foot examination. And the anterior fontanelle is very specific, no, for newborn. So they might go further. So when does that close? When does the anterior fontanel close? When does the posterior fontanel close? Any idea, Vigneshwar, when does the anterior fontanel close? When does the
It
posterior
closes,
fontanel?
anterior fontanel closes in about 18 months.
Okay,
And
very
the
good.
posterior fontanel closes about 3 months.
3 months. So early. So 6 weeks, 6 weeks to 10 weeks. So it will be very smaller. Even you cannot insert your finger, no, the posterior fontanel. Then they will ask you what are the causes for delayed closure of the anterior fontanel. A lot of questions they can ask about the sutures. You're mentioning about the sutures. Then and fontanel. Then this important question they will ask you: how will you differentiate cephalometoma and caput succedaneum? You should be able to say the points. So how will you differentiate cephalometoma and caput succedaneum?
Yes, caput succedaneum, it occurs in the subcutaneous plane, sir. Whereas cephalometoma occurs more diffusely. And cephalometoma occurs in particular over the parietal bones. And the caput succedaneum occurs more diffusely and crosses the suture lines, whereas the cephalometoma doesn't cross the suture lines.
So very important, no? So it's subperiosteal, so it doesn't cross the midline, doesn't cross the sutural lines. So succedaneum is edema, it's a diffuse edema, so it's going to cross the sutural lines. And it subsides very fast, succedaneum, but cephalometoma might take even 1 month for the hematoma to subside, and it is an important cause for neonatal jaundice. For your case, you are having jaundice, no? So you have to ask. Ma'am, anything, ma'am, in this part?
Yes, sir, fine.
So, okay, but next slide. So remaining head to foot part.
Yes, sir. So yes, it is normal in size, shape, position. Elastic recoil is present instantaneously. No abnormal tags or hair present in pinna. Nose, septum, alae, bridge, and philtrum appears normal. Neck, normal neck movements are present. No swelling or other abnormalities. Lips and mouth, normal with no cleft lip or cleft palate. Chest, yellowish discoloration is present up to the umbilicus. Nipple bud measures about more than 5 millimeters. Areola is well formed. There's no widening of nipples, no axillary nipple or intercostal retractions present. Umbilical stump, it appears healthy with no periumbilical erythema, discharge or meconium stain. The umbilicus is central. External genitalia appears to be normal. The extremities, limbs, digits, palms, and soles, there's no icterus or pallor present. Anal opening is present and patent, and skin appears yellow over face. Chest up to the level of umbilicus. There's no birthmarks or neurocutaneous markers.
Okay. Ma'am, you want to add anything?
Yes, sir. It would be better if you mention the external genitalia. What is it? As you have mentioned everywhere, elastic recoiling is there. Nipple bud is more than 5 millimeter. So if it is a boy or girl, so according to the Rugasi and the genitalia, what is it present? This child is a boy or girl?
Girl.
Sorry.
Girl, ma'am.
Girl. Okay. So whether the labia majora is closing minora or not, like that you can explain also. Okay. And what are the normal birthmarks that you expect in this child? What are the normal variants that you can expect in this child?
So definitely they will ask you this question. So what are the normal newborn findings? So you can get some features. No? You should be able to say at least 4 normal newborn findings.
Yes, sir. So erythema toxicum.
Neonatorum. Okay.
Then Mongolian spots.
Very good.
Cutis marmorata.
Okay.
And then milia, Epstein pearls.
Okay, good. And salmon patch.
Salmon patch, yes.
So salmon patch. So some capillary hemangioma. So some reddish rash like, no? So salmon patch. Then how you try to describe the lesions. If you describe, that would be even more better. So Mongolian spot, how will it be? It will be like a...
It will be present in the lumbosacral area with bluish red.
Brown discoloration. So no, macular bluish brown, almost like a nevi, large nevi, light colored nevi on the back. Erythema toxicum neonatorum.
Maculopapular rash. Like on
Vesiculo.
vesicle.
Small vesicles with surrounding erythema.
Erythema.
With surrounding erythema. Okay. Then what else you said? So erythema toxicum neonatorum,
Cutis
Mongolian spots, cutis myrmeta. So how will you describe cutis myrmeta?
So it will be like a mottling over the skins.
Like a mottling, but the child will be fine. Child is not sick, but some mottling will be there. Okay. Then
Milia.
milia. Milia will be like comedones, whitish comedones around the nose region. No.
Yes.
Okay. So the anything, ma'am, you want to add, ma'am? Normal findings.
Yes, sir. Fine, sir. Apart from that, is the umbilical cord has fallen or not? You have mentioned as appears healthy. Whether it has fallen or not has to be mentioned.
Okay, ma'am.
That is all, sir.
Okay. So basic in the head to foot, I think you have covered everything. We are looking each and every part for the minor. So any congenital abnormality is present or not. It starts from ears, then you look into the nose, then lips and mouth, any cleft palate, no? Then you look into the umbilicus. In umbilicus, one more important is whether there is any evidence of infection, no? So that's what you have written. Any erythema, discharge, any cellulitis is there. So you are looking for that. And the major congenital abnormalities at the time of birth itself, you would have looked for the anal atresia, no, the esophageal atresia, any frothing from the mouth, no. So those are the major abnormalities. And the umbilicus is good and healthy. You can examine. Then you have to count the arteries and veins, no. So whether there are 2 arteries and 1 vein. So you look for the basic abnormalities from head to foot. Plus, simultaneously, you have also looked for the gestational age assessment. So what is the gestational chart we use for assessing the gestational assessment?
Dr. Vignesh?
Vignesh,
Yes,
do you know of the chart which we use for assessing the gestational age? Ballard's
score.
chart, no?
Ballard's chart, yes.
Score. So in that you have neurological criteria, you have physical criteria. So definitely they will ask you. So how will you differentiate a preterm and term? Can you tell few points? Physical, if neurological, if you say well and good, you will get more marks. But at least physical criteria you should be knowing between preterm and term.
Yes, sir. So elastic recoil will be slow in case of preterm.
Good. Of the ear. Okay. Then.
And then the heel to ear maneuver will be easily performable in preterm.
Because less tone is there.
Less tone is there.
Is less. So the leg heel can go till the ear. Okay. Then.
And then the square window phenomenon. This baby's hand will be flexed on the forearm.
Okay.
And
so how will it be? Preterm and term, how will it be?
So in preterm baby, in term babies, the joint will be able to, in term babies, the wrist will be able to touch the joints.
No. In preterm, it will be stiffer. And it's very difficult to touch the elbow aspect, the hand. But in term, you can, the angle will be less because stiffness will be less. In preterm, stiffness will be there. So the square window alone will be different actually compared to other tones. All the angles, term will have good tone and acute angles. Okay. But this square window alone, term will have acute angles. So preterm, it will be difficult to touch the elbow. Okay.
Yes, sir.
But more, I think, more than the neurological, the scarf sign, where the elbow cannot be crossed beyond the midline for term babies, but for preterm, you can cross beyond the midline. So scarf sign is very important, neurological criteria. Then you are talking about heel to ear, you can easily touch the ear. Then arm recoil, you release the hand, it goes back very quickly. In the term babies, and preterm, it's not going to go so easily, no. So it's not going to go back. So once you release, it will be just extended, no. So I think arm recoil, scarf sign, and popliteal angle, it will be acute. So that will be your neurological criteria. But physical criteria is what at least they expect from all the students. So what are the physical features? So one, you said ears, then what else?
Posture, sir. The term baby will have universal flexion posture.
Okay.
Whereas the preterm baby, the tone will be less in preterm. So
okay. So the posture, how is the baby's posture? So again, you are going into the neurological criteria. I think you are into the neurological physical criteria. So one is ear, then is your nipple breast bud, sole crease. So preterms will have less number of creases, but term babies will have initially anterior 1/3, then 2/3, then full sole will be creases. So that will be the creases. Then the breast bud. So how will be the breast bud? So for preterm, it will be barely visible, but slowly as it becomes, you will have a good breast bud, no? Up to 1 millimeter, 1 centimeter, up to 1 centimeter you will have, no? So the areola and the breast bud will be well formed in the term babies. Then what else you look for? How will be the genitalia?
Scrotum will be small and poorly pigmented in a preterm baby, whereas here it's going to be a scrotum will be pigmented and multiple drop will be present.
Okay.
And testis will be
descended. Okay. And for a female genitalia?
The labia majora will,
yes.
Labia majora will cover the labia minora and clitoris in case of term baby, sir.
Okay.
Whereas in preterm baby, the labia majora will be widely separated, exposing the minor.
And clitoris will be prominently visible. Plus, then you will have the lanugo hair. Who will be having more lanugo hair? Preterm term.
So in preterm baby, the lanugo hair will be present.
Lanugo hair will be more present. Then how will be the skin in preterm and term? Skin.
So in term baby, skin will be pale and thick, sir.
Okay, there will be a lot of crackings and peelings, no? Whereas in preterm, it will be glossy and veins will be visible. No? Less cracking. Okay. Ma'am, you want to add anything, ma'am, in the Ballard's gestational ages?
No, it's fine, sir. Everything was covered.
Okay. So you need to have at least physical criteria, then neurological criteria. So basic important thing you should understand that the tone is good in term babies. So there will be a flexed posture and all your popliteal angles will be acute in angle and the arm recoil will be good, no? So that thing you should keep in mind. Okay, continue.
Here on the hip, the ortolani and Barlow's test are negative. In the limbs, normal movements of all 4 limbs are present. The creases are present deep over palms and soles.
Okay.
Systemic examination, CVS, S1 and S2 heard, no murmur. RS, normal vesicular bed sounds are heard, no added sounds or no respiratory distress. Abdomen, non-distended, soft, no visible peristalsis or pulsation with no scars, sinuses or dilated veins. CNS, baby is alert with inconsolable cry. In the motor system, there's normal range of movements with no resistance to passive movements.
Normal range of movements with no resistance to
passive
movements. Okay.
Next.
So the systemic examination, I think maybe it's almost simple. You need not elaborate like usually we do in pediatric cases, no? So inspection, palpation, percussion, that's not needed. Maybe some in abdomen you can add about the organomegaly. So usually 2 centimeter of liver, no? So maybe present, so that you can add up. But otherwise, if you have any murmur, you talk about the murmur. S1, S2 heard, any murmur is there, you talk about the murmur. And RS, any distress is there, any retractions is there, any added sounds are there, any grunting is there. So that you are going to add up in the RS. So basically, the head to foot examination is more important. The systemic examination, mostly you're not going to be in a detailed way of presenting the systemic examination. Okay, continue, Pa.
Yes. Cranial nerve examination, optic nerve. Blinking of eye to bright light is present. That is Meniere's reflex is present. Third, fourth, and sixth nerve. Doll's eye reflex is normal with conjugate eye movement in the opposite direction on turning the head. Fifth nerve, rooting reflex is present. Seventh nerve, no gross facial asymmetry or no deviation of mouth during cry. Eighth nerve, startle reflex is present. Ninth and 10th nerve, there is no history of nasal regurgitation of feet. Sucking and swallowing reflex are present. 11th nerve, normal neck movements are present. 12th nerve, there is no wasting, fasciculations, or tongue deviation.
Okay, but good. So I think cranial nerves are good. So do not say that I couldn't examine. So try to find out such simpler maneuvers to make some way of assessing the cranial nerves. As you have written the Meniere's reflex, Doll's eye reflex to look for the eye movements. Any squint is there, you can talk about the squint. Fifth nerve, I think good, the rooting reflex. Similarly, in second nerve, you can also go for the light reflex, pupillary reflex you can talk about. Seventh nerve, yes, while the baby is crying, any deviation is there or not. Startle reflex is very good. You can talk about the startle reflex. Then ninth and 10th, ask for history of any regurgitation. I think that's a good point about the 9th and 10th now. Ma'am, anything you want to add, ma'am?
No, sir, no.
I think that's...
In case of olfactory, if they ask, you can say that to the breast milk, the child turns the face. So even that smell, the child can recognize if they ask.
Some way of assessing the first nerve also, you can say the baby turns towards the mother's cues, mother's milk, smell of the milk. So the baby can turn like that, you can say. Do not say like it's very difficult to assess the cranial nerves. You cannot assess the power like that all. Don't say. Visible power. The baby is moving all the limbs. There is no asymmetry in the movements. The baby is lifting the limbs above the gravity. So something like that you have to keep adding rather than saying you cannot examine. So like that, don't mention. Okay. Continue. Next.
Reflexes. Morose reflex is positive with symmetrical, bilateral, rapid, complete abduction and extension of upper limbs and opening of hands, followed by slow adduction and flexion with extension of the head on sudden drop of flexed head through 30 degrees followed by a cry. Rooting and sucking effects positive on stimulating the angle of mouth or lips. Babinski's reflex is positive with dorsiflexion of great toe with extension and fanning out of other toes. Grasp reflex is positive when an object is touched on the radial border of palm between index finger and thumb. Tonic neck reflex is positive with extension of arm and leg on ipsilateral side with flexion of limbs on contralateral side on turning head gently onto one side.
Okay, good. I think you have elaborated in detail the neonatal reflexes. So maybe the tonic neck reflex, asymmetric, you put it in specific, there is a symmetric also. So you put it as asymmetric tonic neck reflex. And rooting, sucking, fine. Morose, fine. Grasp reflex. Stepping and placing reflex. You can talk about stepping and placing reflex. Ma'am, anything you can add, ma'am? Reflexes?
Yes, sir. Stepping, placing, gallant and that's it, sir. Symmetric tonic, you can assess. Otherwise, tonic neck reflex. Asymmetrical, you need to mention it. And you need to know the time it appears and time it disappears. Definitely, that will be the question.
Can you elaborate when it disappears, Vigneshwar? Morose reflex?
Morose reflexes disappear in about 3 months of life.
Okay, 3 to 4 months of life, morose. Then they might ask you about what is asymmetric morose.
Yes, sir. In asymmetrical morose reflex occurs in conditions where there is a brachial plexus injury in case of Erb's palsy or fracture of clavicle or fracture of humerus.
Okay, so when will be the morose reflex depressed?
So in case of birth asphyxia, it will be depressed.
Okay, very good. Then rooting reflex, when does it disappear? Rooting reflex?
It disappears about 2 months of life.
2 months of life, very good. Then how about this grasp reflex? Palmar grasp?
So palmar grasp reflex disappears in about 2 months of life.
Okay, then only the voluntary grasp will come. Only when the grasp reflex disappears, the voluntary grasp. So hands will be open. Then the baby will try to voluntarily hold the objects. Similarly, asymmetric tonic reflex, when will it disappear?
Not sure, sir.
So 5 months, 5 months, and because when it disappears, only the rollover will come. So the baby will
Okay,
roll
sir.
over by 5 months of age. So it has to disappear by around 5 months. Then only the rollover will come. So you should know when it will disappear. Similarly, when will it be appearing? So you can safely say it matures by birth, but many reflexes are seen even before itself. So even 28 to 32 weeks itself, moros will be there. No, then rooting and sucking 32 weeks, they will start having rooting reflex, and so you can say that they will be present even earlier, but it will be well matured by birth and till by the. Ma'am, you want to add, ma'am, regarding this disappearance and appearance?
No, sir. No, sir. None.
Okay. Okay, pa. Continue, pa. Continue.
Yes. So summary.
I think koncham back ponga pa. Actually, you just go back. So here you said about the cranial nerve examination, no? Koncham the motor system, maybe you have not elaborated, I felt pa. So you have to talk about the tone. So the passive tone when movement, then how is the tone while lifting the baby, no? So you have at least while pull to sit, when you try to pull to sit, how is the tone? When you lift the baby, how is the tone? And when doing the passive movements, how is the tone? Okay, and how is the attitude? So whether the all the four limbs are flexed or not, so that will be the tone. So just don't stop with the cranial nerves. So tone, then power, make an assessment of the power, make sure at least the four limbs are moving. Is there any asymmetry in the movement? So you said no, Erb's palsy and brachial plexus injury, no? So any asymmetry in the movement, and at least the baby is lifting against the gravity or not. So that part of power you can do. And some reflexes, so the basic deep tendon reflexes, you just check it, and for completion's sake, say that the deep tendon reflexes are present, and plantar you have elaborated. So usually you will have the upgoing plantar reflex, no?
Yes,
So
sir.
that part you can add. Anything, ma'am, you want to add, ma'am?
And that is 180 flip test, as you said, it was not mentioned. This one. That
At
is,
least,
if you the child to sit, okay, whether the head lag is happening or not, you will see. And if usually even in the newborn, what happens is that it momentarily comes to the straight line and then go back. So head lag will be there, but momentarily it comes and get back. Okay, so that part you have to mention. And then whether the child is floppy or not, that is by the vertical suspension. We do it with a vertical suspension, okay? Keeping both the hands in the axilla and then vertically suspending, you will know that if the child is floppy, that will slip out of your limb, or in case of spasticity, if the child is developing, again, you can see it in the lower limb also. Okay, so that part you need to mention. And for all practical purposes, even the sensory, you can ask to the mother that the child cries to the hot water or cold water, whether it's snowing or not. So only that history alone you can ask and put it in the sensory system. That is all.
Okay, ma'am.
Okay, ma'am. Thank you, ma'am. Thank you. So that's what, pa. So that 180 degree, I think you have mentioned all those in the to the start in the general examination report thing, on that part you can put it here to assess the tone, the ventral suspension, prone, general
Okay,
you put it here in the CNS examination. Okay.
Again, it would be better if you put it like a modified Ballard score, and this is the child looks term according to the modified Ballard score. If you mention that, it would be better. As you have mentioned, general examination.
I think as ma'am says, head to foot portraiting examination, you are saying that at the end, I think you can again tell those points. So the ear recoil and all in a cluster, and say your inference. So this based on the physical maturity, it looks like a term baby. it looks like a preterm baby, like that you can talk about. Okay.
Okay, sir.
Okay. Next.
Summary: 6-day-old term baby girl who is immunized with birth vaccines, born to parents of a non-consanguineous marriage by normal vaginal delivery with birth weight of 2.7 kgs, cried immediately after birth, came to TMCH with complaints of yellowish discoloration of skin since 2 days associated with reduced urine output and inconsolable cry. On examination, there is yellowish discoloration of eyes, face and chest till the umbilicus with no other significant findings. Diagnosis: a 6-day-old full-term appropriate for gestational age female baby of birth weight 2.7 kgs with neonatal jaundice is probably a case of breastfeeding jaundice with no complications.
Okay. Ma'am, you want to add anything, ma'am?
Can you get back to the summary thing? Summary slide here. Previous slide.
Yes, ma'am. Yes, ma'am. 1 minute.
Yes. In this, if you can mention the blood group of the mother, it would be better. That will be some clue, because mother's blood group we used to do, no? Like we'll know that. Another thing is face and chest till the umbilicus with no other significant findings. So what significant finding you are expecting? Dr. Vignesh?
Yes, ma'am.
Yeah.
In order to get the clue of the etiology, ma'am, in case if the jaundice is due to hypothyroidism, then the anterior frontal may be depressed.
So you mean that any dysmorphism or any hormonal issue? So you can mention it like that with no dysmorphism, like that. Okay. So in this case, it is very blind, no? Like no other significant findings is to mention, and the examiner, it probes the examiner what kind of finding you are expecting, right? Is it like Kernicterus kind of finding that you are expecting in this child, or etiological finding? So we wanted to know, like, if you are very clear with the presentation, it would be very better for you to get through easily, unless until you give away any words or something like that.
Okay, ma'am.
Okay, one is I think the presenting complaints of yellowish disc. You can just straight away say with jaundice for 2 days. And Kramer's, you said actually Kramer's zone alla sollindingla. I think that all you can put it in here. So how much was the jaundice with Kramer's zone? So up to chest and umbilicus. So that part you can say with no complications, with no evidence of bilirubin encephalopathy. So maybe you can add those things. Okay. Okay, pa. So final diagnosis, Vanga. So diagnosis paranga ma'am. No, idhula mode of delivery add pannala nenikiren. 6-day-old full term AGA female birth weight with normal vaginal delivery and immediately cried after birth. We usually say those things, no? Immediately cried after delivery with neonatal jaundice, probably breastfeeding with no complications and with no other congenital abnormalities. Gravidas status also we usually add the diagnosis.
Yes, sir, sometimes.
Yeah, okay. Okay, ma'am. I think the mode of delivery you can add.
Mode of delivery has to be added here.
Okay, ma'am.
And immediately cried after birth, that part you can put. breastfeeding jaundice with no complications. With neonatal jaundice, Kramer zone, you can put it in the Kramer zone 2 or 3, whatever, with probably breastfeeding jaundice with no complications.
Okay, sir.
Okay, ma'am. Okay, pa. Next, investigations.
So investigations, total
So
serum
and basically, no, the once you have presented, no, you nicely all that, no. So the investigation and all will be more of a discussion type rather than determining whether you pass or fail. So these all will be additional part. Okay, continue, pa.
investigations, total serum bilirubin, transcutaneous bilirubin, blood grouping, peripheral smear, hemoglobin estimation, hematocrit, direct Coombs test, G6PD levels, thyroid function test, WBC count, IET ratio, CRP levels, and micro ESR.
Okay, pa. Okay. So I think fine. Maybe total serum bilirubin vandale, how much is your direct and indirect bilirubin? So that component you can add in this. Okay. And maybe preliminary investigation, second level investigation, you can differentiate it. So we don't do G6PD level straight away for all cases, no. So you can have a preliminary investigations. So where you look for the hematocrit, bilirubin, blood group, no. Then, as you have nicely pointed out, you are looking for the sepsis, I assume. So WBC count, CRP.
Yes, sir.
But what is most important for sepsis? Most gold standard investigation for sepsis? Blood culture, no?
Blood culture,
So blood
yes, sir,
culture.
blood culture.
Blood culture should come here. So you can put the preliminary investigation for jaundice, preliminary investigations for sepsis, then second level investigation, go for your G6PD levels, then extra investigations you can add there. Okay, ma'am, anything else you want to add, ma'am?
Yes, that is all, sir. Whenever you are going to mention like WBC IET ratio, you mentioned that to rule out sepsis, or as sir said, preliminarily I will do everything for these kind of group of tests for every jaundice style, and if these are all passed, then we will go for a G6PD deficiency and all. So make it in that order, or at least tell that these are the preliminary we will do, and these are all to rule out sepsis, to rule out something. That is all.
Okay. Okay. Pa. Next. Pa.
Treatment, continue breastfeeding and phototherapy. In case of severe jaundice, intravenous immunoglobulin is given and double volume X-ray transfusion is given.
Okay, so most important treatment will be breastfeeding here. So it's probably poor feeding. So you have to look into the breastfeeding issues. Mostly there will be attachment issues. So try to counsel the mother regarding proper breastfeeding techniques. And if you feel that maybe the initial period, if it's a cesarean, so it might take some amount of time for breast milk to be. So maybe some add-on feeds can be given initially till the mother's secretions are good. But try to promote exclusive breastfeeding. Do not try to add artificial feeding and all. And as you will have a bilirubin nomogram, so they will ask you about nomogram. And based on that nomogram, you will decide whether to go for phototherapy or not. So usually we may not go to that level for breastfeeding jaundice, or if it is needed, you have to give. Okay, phototherapy is needed, and if there is any blood group incompatibility, OA setting, RH setting, maybe it might be even high to needing exchange transfusion also. Okay, okay,
sir.
Next.
That's
okay, ma'am, you want to add anything, ma'am? Management.
That is all, sir. You will be asked about the phototherapy basic theoretical question. What is the complication that you encounter when a child is put to a phototherapy?
And complications of phototherapy.
Dehydration, any diarrhea, hypocalcemia, any retinal damage, tanning of skin.
Very good, Pa. Very good.
Thank God
And that
you
phototherapy
didn't mention
rash.
Down syndrome at first.
And that phototherapy rash is very common. So hyperthermia, most important is your dehydration and hyperthermia. Very good. And you cover the genitalia and cover the eyes.
Okay. And what are the mode of phototherapy that you will be giving? All these are theoretical questions. You can go ahead. And definitely they'll ask, why do you say this is a physiological jaundice? Why it's not a pathological jaundice? What is the difference between the breastfeeding and breast milk jaundice? What do you do for that? So these kind of questions you need to be prepared for.
And as we say, continue. I think he said about pathological jaundice, ma'am. In the history itself, I asked physiological, pathological difference. He said that. I think discuss ocean. So they will go into deep. So prevention of hypothermia is a very important. So they will go deep into it. Then preterm babies, feeding of the preterm babies. So Paladay feed, Gavage feeding and all. No? So they can go. Then birth asphyxia, stages of birth asphyxia. How will you manage birth asphyxia? So I think basic newborn care, you should be knowing all. So basic newborn care, they will ask, and rest whatever basics we discussed, I think they are going to discuss. No? Any other topics you suggest, ma'am, that in newborn they will be definitely asking these questions?
Sorry, sir. I'm sorry.
Any topics you suggest, ma'am? Like these topics you are supposed to read and keep.
Okay. These three things only, sir: hypoglycemia, hypothermia, and breastfeeding part. How you feed taking care of the preterm, and then
Yes,
IDM mother.
Yes, ma'am.
Infant of diabetic mother is very common, and what are the congenital anomaly that we usually encounter in the case of GDM, and IUGR. What is the difference between the preterm and the IUGR, and what is the state of IUGR?
Ma'am, hello.
Internet
issues are there. No? Okay. Yeah. No audible. Okay. No audible.
So Down syndrome, antenatal screening, and all they may ask.
Okay. Okay. Sure,
so
I think
anomalies is very much important in this case. In the newborn, definitely they will ask about it.
Okay, Vignesh. I think Vignesh has done a wonderful job. The presentation is good enough. I think you will pass out with the good marks the way you have presented. I think it's good. And all the questions you are able to answer. So you have prepared well. So I expect all the students to prepare in the same manner. And any doubts for Vignesh? Raghu, you have any doubts?
No, sir.
Okay. So keep reading well. Okay. I think we can wrap it up. So
thank you so much, sir. And thank you, Vignesh. It was a great session. And thank you so much, sir, for joining with us. And thank you, ma'am, for joining with us today. So we will be having a future session similarly, with which will be covering at least 2 or 3 cases a month. And we thank Dr. Balaji, sir, for continuously supporting us and guiding us in the academics. Thank you so much, sir.
Thank you, Raghu. Thank you, Vigneshwar.
Thank you, sir.
Thank you, sir. Gayatri, ma'am. Thank you, ma'am, for coming. Actually, you had your duty. Still, you have joined us. Thank you very much.
Thank you, ma'am.
Thank you, sir.